Hello, everyone, and thank you for attending today's webinar. Before we begin, we'd like to cover a few housekeeping items. At the bottom of your audience console are multiple application widgets you can use. You can expand each widget by clicking on the maximize icon at the top right of the widget or by dragging the bottom right corner of the widget panel. A copy of today's slide deck is available in the resource list widget, indicated by the green file icon at the bottom of your screen. If you have any questions during the webcast, you can click on the Q&A widget at the bottom and submit your question. We will take questions throughout the webcast. If you have technical difficulties, please click on the yellow Help widget. It has a question mark icon and covers common technical issues. You can also submit technical issues via the Q&A widget. Please note, most technical issues can be resolved by pressing F5 or Command-R on Macs. Finally, an on-demand version of this webcast will be available approximately 1 day after the webcast using the same audience link to join today's event. Now, I'd like to introduce Candace Talkington. Candace, you now have the floor.
Thank you, Brian. My name is Candace Talkington, and I am with Mathematica. So glad to have you for the COVID-19 Health Data Users Group. This is a user group collaboration with the National Association of Health Data Organizations and Mathematica. And our session today will be a roundtable with some excellent panelists. So excited to have everyone here. We will start with sharing some resources that we've put together for you. We've shared some of this with you in previous sessions if you've happened to attend. But as we get more information, these have been updated, so we want to make sure that you have that information and access to these resources. As I mentioned, we do have some excellent panelists that will be sharing their experience using COVID-19 data with you today. So a couple of resources I wanted to highlight for you is a data primer. This data primer is a collection of information that's really designed to help researchers, data scientists, and others to analyze healthcare data to better understand the track COVID-19 information. We also have a contact tracing tip sheet, and I know this is top of mind for a lot of you, especially now. This fact sheet it provides information about establishing a COVID-19 contact tracing program, and the link is provided for you there. The other thing I want to share with you is a risk calculator. It's very exciting. It's called 19andMe, a COVID-19 risk calculator. This tool provides an individualized approach to evaluating COVID-19 by looking at risk factors such as a person's location, their age, their sex, pre-existing conditions, and their behaviors. What's a little bit unique about this one, this risk calculator, is that it goes all the way down to the zip code. Some of the risk calculators out there or the information that we have is on the county level, but this particular one goes all the way down to the zip code level. So there's a link for you there as well. If you have any questions about these resources, my contact information is at the end of this presentation, so feel free to reach out to me or anyone on that contact list, and we'd be happy to assist you. So as I mentioned, we have a great panelist list. We have a great list of panelists who are going to share their experience using COVID-19 data. First, we have Melody Kraft. We have Michael Trenu. Aria Robichuk may not be able to join us today, but we are excited to have Melody and Michael here with us. Facilitating our roundtable discussion is Joel Aria with Manat Health. And with that, I will turn it over to you, Joel.
To one of the speakers, you're turning it over?
Sure, I can do that. Melody, if you would like to start, give us a quick introduction about what you're doing, how you're working with the COVID-19 data in your work.
I think I have activated everything, right? Mute off, and I'm advancing the slides. Okay, so I'm Melody Kraft. I'm from Milliman MedInsight, and I'll be introducing you to some of our analytic resources, modeling, and early experience. My background is in medicine, research, and business. Note, I'm not an actuary, but I collaborate with many actuarial colleagues. So Milliman is an independent global consulting and technology firm whose mission is to protect the health and financial well-being of people everywhere. Within Milliman, MedInsight specializes in advanced analytics solutions to support payers, providers, and employers. We partner with actuarial, clinical, and managerial consultants across Milliman. A few quick caveats are that the situation is evolving on a daily basis. Our understanding changes as new evidence emerges, and just simply that my contributions to this panel discussion are my opinion and should not be attributed to Milliman. To help organizations assess the impact of COVID-19, we've approached this from a number of angles. We released a pragmatic analytic guide in April in a white paper titled Frameworks and Considerations for COVID-19 Related Analyses. Then we implemented this into data-driven dashboards that organizations can utilize for their own data. 3 starting point dashboards are on utilization trends or resource use, prevalence, and high risk. For the subset of clients that contractually allow us to, we are aggregating data on a near real-time basis. This subset represents over 20 million lives, commercial, administrative service organizations, Medicare Advantage, and managed Medicaid plans. We're seeing the anticipated increase in telehealth, detecting testing from March onwards, and have begun seeing patterns in the diagnosed COVID cases reported in the incoming April data. Monthly data feeds are automated from many organizations, while APCDs currently get data less frequently. A quick snapshot from my colleagues' work on experience reporting of pharmaceutical claims and costs. This is near real-time tracking from the start of 2020, showing spikes in hydroxychloroquine, following the president's comments in March, and spikes in albuterol inhalers used in COVID management, which all led to shortages of these drugs. In his work on leadership, Andy Stanley expressed the art of being clear in the face of uncertainty. We leverage analytic tools as well as modeling insights to help clients explore trends in their own data. Costs, utilization, patterns in virtual care modalities, understanding that not everyone has access to video and on internet, stratification of persons at high risk of adverse outcomes, deferred care, resumption of care services, and IBNP, incurred but not paid estimates. The Milliman team developed modeling to help organizations estimate the financial impact in 2020, outlining key assumptions and modeling multiple different scenarios, looking at the costs of COVID-19 testing and treatment and costs of deferred and eliminated care. So by market, Medicaid, Medicare, commercial, and by region. It's described in the white paper at the top here and regularly reviewed and updated with new knowledge as needed. This second example is a model estimating both the impact of deferred and canceled medical services due to the coronavirus pandemic and the potential return of medical services previously deferred. The model incorporates clinical and actuarial input along with emerging experience to estimate impacts under a variety of scenarios. And I thought I'd leave you with this. This is a small fraction of the many research papers and resources available at Milliman. So I'm not going to step through them all here, but you'll have access to these. And there are many more. So when you click on the site and go to the links, there will be plenty there. And I've provided a few contact details, so please reach out to us if you'd like further information on or resources on specific questions. So I'll hand back over unless Michael wants to speak next.
I'm able to speak. It depends what
Great.
You all want to go. Candace, you might be muted.
Aha, as I unmute, thank you. Michael, if you wouldn't mind sharing with us a little bit about what you're doing currently related to COVID data and perhaps share some of the challenges or opportunities that you've come across most recently.
Sure, thank you. And thank you all for being here. A few things. First, by way of introduction, my name is Michael Chernew, and I'm a professor of healthcare policy at Harvard Medical School. I also was recently named to chair the Medicare Payment Advisory Commission, or MedPAC, and so it's important for me to say at the onset, the views and the comments I make reflect my thinking alone and are in no way reflective of anything that MedPAC has been doing. I've only been MedPAC chair for 5 days in any case. So with that said, let me pick up a little bit where Melody left off. I've been doing a lot of thinking and measuring of the volume changes surrounding the COVID epidemic sort of overall. We got some data from large health IT company, Phreesia, and we've been tracking changes in visits over time. And so to give you some idea of the data, by the third to fourth week of March, overall visits from baseline were down over 50%. But subsequently, by the week of May 10th, and we just published this with the Commonwealth Fund, and you could see the actual slides online, we had a rebound where now overall visits were down only about 30% from baseline. So normally, if we would have said there's a 30% drop, that would have been a disaster. It turns out that 30% is particularly good if you are comparing it to a 50% drop. We've seen differences across the different census divisions, as Melody said. But again, the most important thing to understand is all census divisions have been hit very hard. New England has done amongst the worst, at least by worst I mean had the biggest drop in visits, and South Central has had the least. But again, even South Central, the drop is net of a little bit more than 20%, and in New England you're down a little bit more than 40%. So we've seen that type of information. We've focused a lot on telemedicine and the role that telemedicine has played in dampening this decline in visits. And in fact, you would see that without telemedicine, declines would now be down 40%. They would have dropped almost 70% at the nadir of the utilization. With telemedicine, you're back to that total number I gave before of a drop of around 30%. So there's about a 10% telemedicine volume going on. And if you look across specialties, we've seen very big differences across specialties. The biggest drops, for example, were in ophthalmology, dermatology, surgery. All those had very big drops. They've had big rebounds, although they're still relatively more affected. We've seen a smaller initial drop and therefore a smaller absolute rebound in areas like mental health and OBG. But again, if you go online and look for my name and the Commonwealth Fund, you'll be able to find the underlying source charts for all of these bits of information. We looked across different types of provider sizes, and again, while there were some differences, it turns out that the big takeaway message is the COVID epidemic has affected all providers. So there's really dramatic impact of COVID on the delivery system overall. And this has led to broad thinking about what does it mean for overall spending. My general sense going forward is that while some of this will come back, a lot of it won't. Some because, as Melody said, there's going to be accidents that don't happen. Some because people are going to be scared of the delivery system. And some because I think we're going to find that with the economic challenges we're facing, people are going to either be losing coverage or having less generous coverage. So we're going to be going into a world overall, I think, of some less healthcare, somewhat lower healthcare spending. And I guess I spend much of my life worrying about spending a lot, spending too much, and so one would think a reduction in healthcare spending is good. In this case, I'm not as clear. I'm worried that people who really have symptoms that are important aren't getting the care that they need, and so there's no clarity on whether or not the care that's going away is high or low value, and the care that comes back, will that care be high or low value? And I think we're particularly concerned about that. We certainly want the high-value care to come back, and I spent a lot of time worrying about low-value care, how to measure it, what it means, and I think would like to move to a world where less low-value care comes back. So my feeling going into this now is that we're going to have lower spending in 2020, and my guess is flat or even somewhat lower spending in 2021, and maybe even beyond 2021, depending on what happens to benefit generosity, and I'm sure you could find those scenarios in the Milliman reports. The big unknown is whether or not we hit a second wave. If there is a second wave that comes in the fall, we would even see greater drop. And I think it's a real concern. I'm very worried about what this means overall for the viability of providers and issues like provider consolidation and provider exit, and making sure that we come out on the other side of this with a delivery system that is still capable of providing the care that Americans need. In addition to that work, and I'll try and be brief, we're doing some work on the risk pool. So there's been an enormous attention to the type of questions I'm talking about now. In one of the Milliman reports that Melody put up, you will see there is some suggestion. There's one of those that relates to the risk pool and changes in coverage. There's a rotation from commercial coverage, for example, to Medicaid and perhaps on the exchange. I should have said I'm also the vice chair of the Massachusetts Exchange. It's called the Connector. Nothing I say reflects the views of the Connector, by the way. But in any case, we're worried about that type of rotation and coverage. But more broadly, in the commercial pool, the nature of who is losing coverage is very important for what premiums are going to look like in the coming year. And we don't know very much about how the risk pool will change, and we are trying to get some data to track that. One last thing. Some of you who know me understand that I spend a lot of time working on a concept called value-based insurance design, which tries to think about how co-pays can be aligned with value. And in many of the rules that have surrounded the COVID epidemic, you've seen the principles of value-based insurance design put in place. For example, waiving patient cost sharing for COVID testing would be an example of that. And I think we really are going to need to think through going forward how benefit design might both encourage the return of high-value care, but not encourage the return of low-value care. So again, to summarize, much of my work focuses on tracking the volume of care, both as it drops and as it rebounds, looking at the risk pool changes, understanding how benefit designs like VBID might support targeting utilization changes in cost sharing going forward, with an emphasis on understanding the patterns of care related to patterns of low-value care pre and post-COVID. So with that, I'll turn it back to Candace, and I look forward to the comments and questions.
Thank you, Michael.
Candace, is this where you want me to pick up, Candace? Or I'm sorry, I wasn't quite sure what's next.
Thank you, Michael. Can you all hear me all right?
Yes.
Great. As I mentioned, we have Joel on the phone. Joel is joining us from MNAT. Joel has been a managing director at MNAT since 2012. Previously, he was a state insurance commissioner in Oregon and Pennsylvania, and is also the first director of the Federal Office of Insurance Exchange. He was also at the NAIC officer and executive committee member for a decade. Joel, I wonder, as our facilitator, if you have some follow-up questions for Michael or Melody.
Yes, I have many questions. Great presentations there. I want to start with a theme that you both mentioned, telemedicine. I think it's the most notable change in the way healthcare is delivered. I've been amazed at how quickly the insurers have picked up on it, from the changes that were first made in Medicare and Medicaid, and now kind of in the commercial market as well. So I have two questions for both of you. One, a crystal ball kind of question. Is this here to stay? What do you expect to see in the future with telemedicine as this pandemic eventually goes away? So that's the first question, kind of where are we going with telemedicine long term? And then secondly, what kind of data issues do you see there? I know we've got a very data savvy audience, so what kinds of issues do you think that the switch to telemedicine raises for those who are trying to collect and monitor the healthcare system. Maybe start with you, Melody, since you were, or go ahead, whichever way you want to go.
I didn't mind. Okay. Well, I think there's sentiment that a lot of people have really enjoyed telehealth, that convenience to be able to access care from home. So this does, extrapolate further into home-based care, but the telehealth components and all of the virtual care modalities, so whether they're online check-ins, e-visits, the telephonic audio only, total telehealth with the video component. I mean, all of those are valuable factors. I'd say the same for the remote physiologic monitoring, and that I think is quite important to help patients get to care on time. So I think the hope is that it will stay. I think some of the learning curve in this, providers have invested and learned to implement these virtual care modalities, is that we're still seeing some incompleteness in the data. And so just anecdotally, all the sequences that would normally happen with a physician assistant or a nurse who might have the patient and gathered a lot of the extra data on their normal biometrics, on changes that have been made, on comorbidities and allergies and medications. That's not always happening. And so as clinics have reduced staff or reduced hours for those particular staff, that outreach to a patient to collect that data, which normally accompanies the physician visit, we're I don't know, a little concerned and watching whether or not that completeness will be there. So let me hand over to you, Michael. What are your thoughts?
Yeah, so Melody, how do you expect that data to be collected? So as you're saying, there's kind of a dearth of some of the data when people are just doing phone calls. How is that going to evolve back towards less phone calls, more kind of setups that allow for sharing of data beyond just the verbal data?
I have not polished my crystal ball, but where we're trying to assess the telehealth modalities is some level of concern about potential disparities. And so if we're trying to address the older, more vulnerable population, we just want to be aware that not everybody has access to a smartphone or a computer or strong internet bandwidth. So we've got to pay attention, I think, to those audio-only components. And I believe the picture is evolving there. I've seen coverage expand, certainly from CMS and others. But there's inclusion in some of the attribution, but not necessarily in risk adjustment. So there are questions remaining there.
So, Michael, I'm we've shared some podiums before, and I'm a big fan of your work on value-based purchasing. So, where's your crystal ball on what's going to happen with telemedicine, and how do you see it impacting VBP?
Yeah. So, first, let me say that prior to the COVID epidemic, I was a big supporter of telemedicine with some caveats. The support is because the only way the American healthcare system is going to be successful in the years ahead if we can find efficient ways to deliver care, and telemedicine of all types may be a way to do that. And there's really been tremendous growth in the related technologies around telemedicine. And I think it's really important as we strive for a more efficient delivery system to use new care delivery modalities that might be more convenient and of lower cost. So that's the plus side for telemedicine. The downside of telemedicine is that it has the potential to dramatically increase volume, perhaps volume that isn't particularly needed. And so there's some concern. For example, we've changed the payment rates. For example, during the epidemic, there'll be a question about what happens after the epidemic, to be concerned essentially about overutilization of telemedicine services. Our data, that is in the Commonwealth information that we presented from Frisia, which is the company we worked with, is that by the middle of April, telemedicine had grown to about 12% of total visits, and at least through the beginning of May, which is admittedly a short time, it seemed to have kind of flattened out at about 12%. So I'm not sure how far telemedicine will broadly take us, and that's the percentage of visits, and remember the denominator is changing, so there's a lot to observe there. My gut feeling in terms of crystal ball is what happens to telemedicine will have a lot to do with the policies that we put in place around telemedicine. How much do we pay, and how do we encourage it? To connect this, Joel, to your question, which I think is great about value-based purchasing, is one of the problems with telemedicine is putting it into a fee-for-service system where the incentives for use and the incentives for monitoring efficient use of telemedicine are much harder to put in play. In the context of any type of alternative payment model, I think telemedicine makes even more sense than it otherwise might. And I think we need to think through how those regulations are designed and how we structure the cost sharing, how we structure the payment for associated telehealth visits. Again, I think our goal has to be to create an incentive system that basically promotes the efficient use of telehealth visits in a whole range of ways without encouraging overuse. And that's going to require some combination of policies related to payments and policies related to benefit design. And we will see where that goes. Right now, my sense of delivery system is our biggest problem is insufficient access for people that have important chronic conditions. And in that environment, I think all of the efforts to promote use of telehealth are absolutely essential, and I applaud the work that we've done. And going forward, we will have to figure out the timing of any changes and what those changes might be. And that's going to require continual monitoring of telemedicine across the system.
Great, thank you for those. So telemedicine's up, but as Melody, as you said, overall volume, I think Michael, you said it too, overall volume is down. Obviously, the insurers are getting a bit of a windfall at the moment. No one knows how long that will last necessarily. The providers are hurting because of that. But Michael, I was particularly interested in the fact that you said that seems to have changed from a 50% drop in March to more like 30% in May. So do you see a kind of steady growth back in that, or what is going to happen? And then Melody, you talked a little bit about the pent-up demand issue and what might return. What do you think is going to happen there?
So I'll defer to Melody, who's done a lot more of the modeling with the Milliman folks about where things are going, and she can confirm or refute the data I presented. My hunch, and again I'm going to refer to Melody, is that we will see a continued rebound, but I don't see us getting really above where we otherwise would have been for a while because of a combination of fear of the healthcare system given COVID and benefit generosity changes, job losses, things like that. So I don't think providers are going to be facing the demand for care that they otherwise would have faced for some time. And I can be vague because Melody will describe what some time means. I do want to say something about the insurers and their windfall. It certainly does make sense to think of insurers getting a windfall, and in some ways, of course, they have as claims costs go down. But remember, in certain markets, for example, the ASO market, the windfall is actually not accruing to insurers. It's accruing to the employers because it's administrative services only. And so you're not seeing that particular savings. And to the extent that there's really a windfall, that's going to be absorbed to some extent by the medical loss ratio rule. And we're going to have to wait to see how that plays out. Here in Massachusetts, we have medical loss ratio rules that are above the national average. I think they raised it. It was around 88. I think they may have raised the medical loss rules a little bit higher. It differs a little bit by market segment. But in any case, the point is much of the windfall would go back to consumers, although that would have to happen with a lag because the MLR doesn't happen until well after the year ends. Insurers are facing a series of other challenges that make me wonder how much of a windfall they are really getting. There's a number of cases where, for example, they're providing grace periods and coverage, even though they're not collecting premiums, with the hope of collecting those premiums, though it's not completely clear to me how much of those premiums will come back. That's another Melody question. And there's some other costs that they are incurring that they did not envision when they set their original rate. So this would, again, offset the windfall to the extent that it's not picked up by the MLR. Things like testing costs and co-pays, waiving co-pays for various other types of treatment. And there's a big concern about people getting out-of-network care and how that's going to be paid. So I think there's some added insurer costs that are all going to have to get sorted out in the wash. And as time goes on, we'll figure out which of the Milliman strategies, which of the Milliman scenarios turned out to be the one that we're living in. Insurers also, I think, got hit pretty badly by the stock market, which is one of the ways in which I think their business model is set up. So I don't think COVID has necessarily been good for any of the sectors. There is certainly some wiggle room for insurers that were well above the MLR to do even better, but I think a general premise that they're all reaping a windfall is probably a little overstated. Joel, you would understand that as well as anybody, and your thoughts on that would be appreciated. But maybe Melody can describe how any of those phenomena, since they're potentially occurring, are captured in the Milliman scenarios.
Yeah, let me just, Melody, before you speak, let me just add a couple little twists to this, because I'm very anxious to hear what you have to say on this, too. So on your point, Michael, I know literally every insurance commissioner I talk to says it depends on the insurer. Some of them are still, struggling. Some of them were doing quite well before and are continuing to do quite well. So it's definitely not painting with a broad brush type of situation. It just depends on your business model. And to that point, Melody, answer the general questions here, but one thing I'm particularly interested in, it's really a tale of two markets. The large group market is really, even the insured part of it is like self-insurance. Essentially, large employers pay an experience rate based on their claims. So if there are any gains to be made in the large employer market and in the ASO market, they're going to accrue, as Michael said, to the employers. It would be my view, not to the insurers. They're going to just, they're just basically a pass-through mechanism on those larger contracts. It does matter a lot, to rating in the small group and individual market where the rates are set, and so if the insurers have to pay fewer claims, they're the ones to gain and maybe pay it back in MLR. But they're two different markets. So add that into the mix as you respond to the questions about where we're headed on insurers and pent-up demand and kind of their overall financial situation.
Yeah, and I don't know that I have a huge amount to add to what's already said. So we are paying attention to that MLR, and different for large groups and small groups, as you point out. And we think that if there is windfall because of the MLR rules, there could be premium holidays or certain adjustments made. Now, whether that happens right now or actually happens at the end of the year is what we're waiting to see. So there are some tricky rules around that. But there's also this pent-up demand. So when you talk about the model, and I won't speak to specifics on it because it's very nuanced. So thinking about the region, the type of service or diagnosis or procedure, so where that site of service might be, a lot of the other parameters, if you're thinking about the extent of lockdown, but also when you look at some of the joint statements from the American College of Surgeons, the anesthetists, the AORN, the AHA, there's a lot of considerations there for the capacity of the facility, supplies, staff across all phases of care. So, early and the procedure and then post-acute, imaging, pharmacy is really all got to be present there, as well as then the patient sentiment for whether they feel comfortable coming back. So there's so much at play. It's hard for me to have any kind of crystal ball on what's coming back when, but their anticipation is that people are getting ready for that assumed pent-up demand, and we're going to be tracking that closely and helping guide people through it.
So it sounds like there's a little bit of disagreement. I don't know how much we want to explore this, but, I hear Michael saying, the pent-up demand is probably not going to come back until we find out whether there's a second wave and, we get to a new normal, whatever that is.
That's true.
And I hear you saying maybe it comes back a little quicker, like maybe even later this year rather than next year, or what do your models tell you kind of about how quickly? Again, I guess you have to assume not a draconian second wave, but is pent-up demand a 2021 issue, or is it potentially coming back even in 2020?
I think we're hearing from some organizations that they're readying themselves for a really high demand. And their limit will be the capacity of the hospital staff and supplies like personal protective equipment. However, if it does coincide with second wave COVID or flu or anything else that goes on, and there are some epidemiology studies that suggest that it's not a simple second wave, it could be a prolonged first wave, but lots of little ups and downs as we are gradually opening up. Maybe as we're doing surveillance and testing, we're really establishing thresholds for when do we need to scale back? When can we be freer? So all of those factors come into mind. And that's why I don't think I can just say, when is it going to happen? Now, if people are preparing, will the patients come back and the procedures come back now? Or will it be later in 2020 or into 2021? So I will, defer to colleagues who are expert on that particular model. But from what I'm seeing, there's a lot of factors at play.
So one
Michael,
of the questions
please.
that I know data mavens really like to explore is these pretty distinct market segments, right? I am going to get a question, Michael, for you eventually on MedPAC, what's happening with Medicare. But right now, kind of this issue of 160 million people in employer-based coverage only 2 months ago, 40 million of them out of that coverage now. Maybe COBRA gets subsidized and, we have a virtual ESI market. If that doesn't happen, the predictions seem to be, 20 million more people in Medicaid, potentially 10 million more in the marketplaces. What kind of data issues interest you guys about that set of potential big-time changes in terms of, I think, Michael, you referenced that you got people who've been working, so that's probably generally a healthier population, and also people who chose not to get insurance in the past, again, probably people who didn't need it immediately. It all looks to me like if there was that kind of influx, it would be good for the risk pools, both for Medicaid and particularly for the exchanges. But why don't you guys respond to what's kind of interesting to you about the data issues related to the potential big enrollment swings we might see here?
So I will say that I do think the risk pool is amongst the most interesting data things. We have a tendency when we see premiums change dramatically to blame the insurers. I think it seems the obvious thing to do. I think we often underestimate the importance of the risk pool and risk pool composition issues, and this became a big deal in aspects of the Affordable Care Act and how it was set up. The challenge here would be, and I'm not claiming this is true, this is why we're looking at it, the challenge would be it is conceivable to me that healthier people would drop out of the commercial market, raising the risk score in the commercial market. Those same individuals might actually they may not be relatively healthy compared to people in other populations, for example, on the exchange. I'm not sure. Joel, you may know the relative risk scores of the people on the exchanges, but you could have differential effects because the commercial population in the exchanges, for example, are not starting at the same risk level. So we will have to see how that all plays out. And again, I'm interested in other people's thoughts. We're trying to track how that plays out. I think the other areas that are going to be particularly interesting data-wise is to understand what's going on with low-value care. I mentioned before we want care to come back, but not the low-value care. So I think it's really important to understand and measure what's happening with low-value care so we can see if as we get through this process, we end up with a delivery system that is more efficient. I could tell you a story why it might be. I could tell you a story why it might be more inefficient, depending on what goes on as providers are serving all the patients that show up, and the general disarray makes efforts to reduce low-value care more of a distraction, and I worry a little bit about that overall. So I'm interested also in understanding, obviously, the health status effects beyond what we're seeing in COVID. I was surprised to learn, some of you may have seen some reports, there have been dramatic reductions in treatment for things like heart attacks and strokes. And I would have told you, I'm an economist, so understand that I don't really know what I'm talking about. I probably shouldn't mention that on this webinar. I see people dropping off. But I would have told you as a non-physician that you wouldn't see a 30, 40, 50% reduction in treatment for heart attacks and strokes. Now, maybe there were fewer heart attacks and strokes going on because people were relaxed at home and soothed by the Tiger King, but whatever it happens to be, that wouldn't have been my guess going in, and I think it's more likely that people are staying away from the healthcare system, perhaps not getting care that they really needed. And so being able to track those outcomes and track those people with chronic conditions and what's happening with them, I think is a really important activity for the data infrastructure to undertake.
Thank you. Melody, what data questions interest you about kind of these potential, what do you see happening with the enrollment swings, where they're going to go, and what kind of data questions are going to be most interesting to try to ask and answer there?
I think that question is beyond my realm of expertise, but I agree with Michael in terms of the concerns about people not accessing emergent care or chronic care or preventive care. So not only was it heart attacks and strokes in that Boston study with, it was kind of alluded to that the mortality rate in Massachusetts went up, and it wasn't entirely explained by COVID-19 deaths. So there is concern that it really has a negative impact on outcomes. And I think in that particular study, they were also detecting some of the decline, though not significant, in patients getting referrals for new cancer diagnoses. And I think that was breast cancer and hematologic cancer, but something that would normally be very concerning, as if heart attack and stroke isn't already very concerning. People weren't seeking care. So I think the push there was to reassure the public, notify that, places are still open. There are a lot of safety measures put into place, and we really do want to pay some attention to that. But the enrollment shifts, I don't know how immediate that is. And so the economic impact is immediate, is felt right now. But in terms of that 90-day window for COBRA, the options to either enroll for individual or for Medicaid, or some we anticipate will be uninsured. I mean, I think that's what we're looking to see. And I believe some of the people who are on furlough are still getting health coverage. So it's something that we're watching, just as Michael said.
Thank you. So I have a lot more questions, but Candace is telling me that there are some audience questions which I somehow can't access here. I think it's probably my problem, not the computer's problem. But Candace, do you have those questions? Do you want to ask a couple of them?
Sure. Thank you, Joel. So one question came in from Stacy. Her question is, with the hospital revenues, drastically different now, given that there's no the procedures that they're doing now are different. What opportunities do we see with testing other value-based models?
Is that for Melody? Might be on mute, Melody.
I don't think so. I think for value-based care, Michael, do you want to take that?
I don't have a I'm sorry for stuttering. I think the overarching thing about this whole COVID experience is almost everything is unprecedented. And so if you would have asked me, and let me emphasize, I'm speaking as me, I am not speaking as any other organization that may be affiliated with it. I am explicitly not speaking for MedPAC, which is a commission-based process. But if you would have asked me beforehand, I would have said, we have a lot of different value-based payment models in a range of different ways, and we haven't sorted out how they will all work. All of those models will be challenged by COVID, and understanding what new opportunities arise, I think, are going to be particularly challenging in how that plays out. So I think we need to understand what's going on and figure out how we can take the models we have and make them work better and better together. And I think that is my general view is it is going to be hard to start things new in an era around COVID, because one thing COVID will do is it'll just completely screw up the benchmarks and the baselines for all the subsequent performance years. And so I think right now we're going to need to think through in both the private and the public space how to just maintain the progress we've made and see if we can build upon it, for example, in supporting telemedicine. But I don't think we're going to look for opportunities for dramatically new models, although I must admit that others may have ideas that haven't yet crossed my line of sight.
Candace, you have another one there?
Yeah,
So speaking of telemedicine,
a couple questions. Excuse me just a minute. Speaking of telemedicine, there's a couple questions. One is related to fraud. This, certainly now that we've opened it up to different platforms and, the rules are changing, at least temporarily, there's an increased risk of fraud. And then the other question is how to address, the access to rural areas or underserved areas to internet to allow for telehealth use. So I don't know if Michael, if you want to start with that. Answering that one.
Yeah. So this is exactly what I was talking about before in terms of my both cautious support of telemedicine. Telemedicine offers great potential. I think there's no doubt about that. But in the fee-for-service environment and what we've done with payment models, fraud may be a concern. I don't want to dismiss it, but even well-meaning overuse becomes a concern, which is really not the same as fraud. And so I think obviously one of the places where telemedicine is most promising would be in rural areas, and the access to telemedicine in rural areas is a problem much bigger than COVID. But even apart from that, I think what we're going to need to do is, if we want to expand access to telemedicine or a range of other types of services that are more convenient and perhaps less expensive to deliver, we're going to have to build models of reimbursement and care that use those things efficiently. I think one of the things that we sometimes forget is any given type of medical modality can be done appropriately or inappropriately, too much or too little, and how it gets used depends on the systems that we put in place around its use.
Michael, let me get one in on Medicare here before we finish. Then, Candace, I'll come right back to you. As disproportionately affecting elderly folks, seniors. What does this do to Medicare kind of cost drivers, and kind of what does that mean for the future of the Medicare program?
So first, let me emphasize again, I'm speaking as Michael. I am not speaking as MedPAC. And in case you stepped away to get a cup of coffee, I'm speaking as Michael. I am not speaking as MedPAC. I haven't even finished my paperwork to become MedPAC chair. But I have been interested for a long time in the health, the fiscal health of the Medicare program, as well as the health of the Medicare beneficiaries. There's a number of things that are going on. On one hand, Medicare, like every insurer, will be spending less on non-COVID care. On the other hand, the costs of COVID will be much greater in the Medicare population than they would be in the under 65 population just because of the clinical characteristics of COVID. And so we will have to see over time. I have not seen reports from the actuaries or CBO about how that's going to play out. My gut feeling is net Medicare spending in the era of COVID will be down somewhat, although I'm not sure that would be a long-run projection for Medicare. And so that's a comment of speculation, not a comment of data. I think the other concern for the Medicare program is the health of the trust fund. So remember, Medicare, particularly the Part A, has a Medicare trust fund, and that trust fund relies on taxes from people that are payroll taxes, people that are working. And as the economy goes into a contraction, and really perhaps the biggest contraction since the Great Depression, it's not clear how long that will last, but nevertheless, the depth of that contraction has been unprecedented. There will be a real decline in the tax revenue going into the trust fund. And I think that's going to be a major concern, and it might be amongst the most significant impacts of the COVID epidemic on the fiscal health of Medicare. So my guess is spending will be somewhat lower net. It depends again on the amount of the rebound, and it depends on the extent to which the additional COVID costs will offset the decline in elective procedures. So we will have to see how that part plays out. But I'm concerned about the loss of tax revenue for the trust fund. And frankly, I'm concerned about the nation's fiscal situation. And again, I will say I'm not speaking on behalf of MedPAC, and MedPAC by and large is not focused on hitting any particular budget target as much as setting prices that are appropriate to preserve access for beneficiaries. But I think anyone interested in Medicare policy broadly, or for that matter, the fiscal health of the nation, has to ask themselves, what does it mean to having a deficit north of $3 trillion, a little bit south of $4 trillion dollars, and how is that going to play out in an era where we might have other real needs for supporting the delivery system and supporting care. So we will see. Right now, I think it's pretty clear, and I think CMS, generally speaking, did a very good job of understanding that when you're in the midst of this crisis, job one is to make sure people can get access to care and they can get the care they need, and that requires providers that are available and able to provide that care. And CMS has done a number of things with some packages from Congress to try and encourage both the survival of the infrastructure and the ability of individuals to access that infrastructure to make sure that we get ourselves through the sort of most serious part of the epidemic. And I think we are going to have to sort out the fiscal situation and a whole slew of other issues once both more data is available and we have more time to worry about that and less time to worry about the actual people that are affected, which right now is by far the most important thing to worry about.
Thank you. Melody, Candace, let me stick one last question in here for Melody, and then I'll turn it back to you to close this out. Melody, on the question of rates in the individual small group markets, how big a factor is regional variation going to be? Is this going to end up leveling out across the country, or are we going to see a lot of big differences state by state or even intra-state?
Okay, Joel, that's a great question, but I am not the expert to answer that. I'm so sorry, but okay. I'm a part of a team of teams over here. But I did want to comment on that audience question on telehealth. And it was, I think, quite a broad question, and I've forgotten all the nuances, Candace. But as you're thinking about fraud and overuse, but also some of the benefits, I was pretty curious to see the impact on behavioral health. So, Michael, you had mentioned that you didn't see that decline as much. And so it's something that we're monitoring fairly closely to see, did that work well for people? Were they able to sustain care in that way? Has there, in fact, been an increased demand in this extremely stressful situation, or the loneliness of lockdown exacerbating perhaps depression, anxiety, and so forth? And then the expansion of the providers now. So not only the types of visit, but also the fact that it pertains to social workers, clinical psychologists, physical therapists. I mean, that has been some of the interesting aspects of the telehealth movement. So I don't know the impact on fraud, as you pointed out, Michael. And I would have to, consult with the rest of my team to learn about how we're tracking that.
Candace, back to you to close us out.
Thank you. I do have one question, and I realize that we have 4 minutes left. So I think, if I just have 1 minute to close this out, if the two of you could maybe take about 3 minutes to answer this question, because I think it's really relevant, and it builds on something that you were talking about earlier, and it's related to accelerating value-based care. Do you think that COVID-19 is going to help accelerate that or slow it down? And then beyond that, is there, after the election, is the COVID-19 pandemic going to stall efforts at overhaul or cost reduction strategies? That's a loaded question for 3 minutes, yeah. I recognize.
Yeah. I don't know if I have time to explain why, but I think by and large, when we get past this, overall, I think we'll find that the COVID epidemic accelerated value-based care, in part because one reason we've had this problem is because we've had fee-for-service. So when volume drops, you see revenue drop dramatically. I think it'll also be the case that they will be looking for new ways to try and improve delivery system efficiency, and I think if done well, alternative payment models, which is a term I prefer to value-based care, will help us do that. And I think we're certainly going to need value-based insurance design if we think cost sharing increases. I don't have a comment on how the broad fiscal situation will play out and how that will be dealt with depending on the election. I think whoever takes over in 2024, would be it the current administration or a new administration, is going to have to grapple with a fiscal situation that we really haven't seen in decades. And I think that will be a fundamental challenge for the nation. I think there'll be differences of opinion about the severity, how bad it is to have a high deficit or debt, and there'll be differences of opinion about how to deal with it to the extent that we need to reduce that debt. Obviously, given the prominence of healthcare spending in the federal budget, and for that matter, state budgets, which states, we don't have time to talk now about how difficult this will be for states. There's no way you can address any of the fiscal problems that we have without some attention to healthcare. And my personal view is there's no way you can find a solution that doesn't hinge on trying to make healthcare delivery a more efficient endeavor. And that requires data, just to take it out.
And I'll comment as well. Candace, is that appropriate? Sorry, I can't hear you.
Yes, thank you.
Candace?
Go ahead.
Okay, all right. I'm not going to comment about the politics and the fiscal situation, but I have noticed some of the opportunities for leadership amongst the health systems as we are doing more outreach to individuals who are at higher risk. So there is a lot to gain, I think, in that population health segment, and making some of these modalities and communications more robust. So I'm certainly paying attention to that, and I know that we're on our last minute.
Well, Michael, thank you so much for joining us. The information you shared with us was incredibly useful and helpful. I appreciate your time. One thing I wanted to point out is that we do have a follow-up session next Thursday. If you haven't registered, please do so. We would love to have you join us for our next session. At the end of this presentation, which has been updated, there were a couple of you that noted that Melody's slides were not included in the download. That's been fixed, and you are welcome to download that. But our contact information is at the end, so if you have any questions or if you need help finding those resources that I mentioned at the top of the call, please do let us know. Thank you all and have a great afternoon.
Thank you.
Thanks, everyone.
Bye-bye.